I've been on this, thank you all for inviting me, it's nice to be here. I've been in Indianapolis for about 17 minutes, and so far, so great. I've been traveling around the U.S. talking to a lot of organizations, mostly DSA locals, about single payer, about health justice, and I'm happy you all invited me to come talk to you. This really is a national fight, but the way it manifests is local, right? Healthcare needs are regional. So I'm here to talk to folks about kind of what the big thing is and try to demystify kind of what single payer is and why healthcare isn't the way it is and why healthcare isn't the way it ought to be, but also to do research, right? Like I've been on the road now for about a week and I've been able to learn what's happening in different places, right? For example, Burlington, Vermont, they're dealing with the fallout of Act 48, which is their state single payer bill, right? So there's a lot of anger and a lot of frustration there at local electeds, entirely reasonably with their snakes. And they want to find out, well, how do we move forward? What do we push for? In Albany, where I was a couple days ago, there's the community is torn apart by the opioid and addiction epidemic. So that's an extremely urgent need that has a really, really massive consequence for that area. Pittsburgh, they've got UPMC, University of Pennsylvania Medical Center, which is both the regional monopoly provider, hospital group in the entire region, as well as being a primary insurer, and also the main employer of Pittsburgh. So a whole bunch of problems all interwoven into that. For example, UPMC hasn't paid their water bill in 25 years because they're a hospital and can't be shut off. They're a nonprofit. They're sitting on about $300 million annual profit margin. Well, I guess non-profit margin, which isn't going back to the community. It's difficult to get access, and they're doing things like blocking med school expansions at other kinds of universities around the state. So that's a really interesting, specific kind of healthcare need. I was just in Ann Arbor last night. They say hello, by the way. Everyone said hello. I'm going to Chicago tomorrow. I'm going to say hello to them. You should tell them. I'll pass on all of their
Tell them hello.
Hi, Chicago.
Thank you. Good. So far, so good. Two folks in the East say hello to Chicago. Up in Ann Arbor, they've got it's a different kind of community, right? You've got a town, because Ann Arbor isn't necessarily a big metropolis, which is next to a large city, which has been just massacred systemically by neoliberalism. The uninsurance rate there in Detroit dropped from 22% to 7% under the ACA, and now a lot of that's in question, particularly with chip financing being on the rails. And then to the west, they've got a really rural area. They've got a lot of Trump voters. So what are healthcare needs there? How do folks feel hosed over in that part of the country? These are things that I get to learn. So when I go talk to other folks and when I kind of build the work that I do, I get to understand kind of all the different fights that are in this. So I'm going to talk to you all for a bit about healthcare, and then I think we're doing Q&A. And hopefully, A, there's a lot of cues that I can add, and B, I should use 1 and 2. 2, I can ask you all some cues about how things look here, how things feel here. That's really, really important, right? So that's where I'm at. And that's where I am right now. For right now, right here, I'm here with you. I'm very excited to talk about single payer healthcare. Quick question before I get into the thing. If I say single payer, or I say single payer versus universal healthcare, how many folks understand the difference, understand what this is, really right out the gate, and could give a talk on it? Awesome. Then if by the end of this you don't think you can raise your hand, you should tell me what you need to know to get you there, right? Let me be a tool you can use to understand kind of what I think we need to fight for. That makes sense? Yeah. Do you solemnly swear to do this thing? Do you? No one said
yes.
Yes. Great. I'm not a fucking politician. People are talking. I'm going to talk about healthcare. All right, let's talk about healthcare. I want to talk about where we're at now, who it benefits, and what we want instead. I want to talk about why we're told we can't have single payer and we got to accept it in its place, and why that's wrong, and what we need to do to realize health justice in America. Sound good?
Yes.
So let me start by describing what we have now. Let's define the shape of the enemy. In healthcare, you've got a bunch of payers and a bunch of providers. Now, providers are folks like doctors, nurses, hospitals, physical therapists, drug companies, the dude behind the counter at CVS that sells me my inhaler every 3 years, when I remember to refill it. When someone needs health care, the provider provides it. That makes sense. Now, by and large, the costs of receiving health care are much, much more than any individual person can afford by themselves. But not a lot of folks need health care in a given year, right? 50% of costs come from 5% of the population. 80% of costs come from 20% of the population. You got some folks that are really sick, some folks that are kind of sick, and then a whole bunch of folks that don't use healthcare at all. And if we made everyone pay for the costs of all their health care out of pocket, millions of folks would go into crushing poverty. And that's not like a guess, that's a thing that we know because it happened. And it wasn't until a bunch of socialists in the 1880s began insisting that letting people go into crushing lifelong poverty because of medical debt wasn't acceptable. We shifted to a different payer model, the idea of insurance. Insurers receive revenue by charging you monthly premiums. When someone gets sick, the insurer takes all the premiums they have and use part of that to pay off a portion of those healthcare costs. But the person who is sick is still on the hook for some of that, and then keep a profit for themselves. So the more revenue an insurer receives from customers, or really the more subsidy it gets from public money, the wider those costs are spread, and the lower the insurer's per person costs, right? So if an insurer has too many sick people, its per person's costs increase, and then it's got to rise premiums to kind of keep pace. That means customers who can't afford those premiums drop out, so the pool shrinks, and then per person costs go up even higher as a result, because sick people tend to stay on board because they're actively using their health care. Thus, an insurer wants as large and as healthy a customer base as possible, so it gets the most money in and spends the least out. Or it wants to find ways to kick out sick customers or coerce them into leaving their plans. And that's what we mean when we say that healthcare, in this world, healthcare is a commodity. Because the future's on your heart, or the future's on your lungs, or your chances of getting diabetes, or whether or not your Mima's glaucoma gets worse before age 65, and she goes on Medicare, are bought and sold for profit by private corporations. Now, in this world, paying for healthcare is very complicated, right? Payers don't all pay the same rates for the same kinds of healthcare. Some insurers pay more, some insurers pay less, some don't pay anything at all, and just pass the bill directly back to you. Whoops. And this fragmented, commodified healthcare model views healthcare as a transaction that only happens when you're insured, with instead of being a relationship between a person, their doctor, and their body, right? We've mistaken the profit motives of insurers for healthcare. That's fucked up. And over time, we've delegated the responsibility of providing insurance to employers. That's not great either, because that results in a status quo of total employer domination, in which your access to things like contraception, or blood transfusions, or hormone therapy are determined entirely by the whims of your employer. But if you aren't lucky enough to have an employer, or if you have the wrong kind of employer, right? If you lack the better skills to get the finite number of better jobs, you're left behind. And the people who profit from the commodization of our bodies have decided it is acceptable to shackle the well-being of children to whether or not their parents were lucky enough to go back in time 40 years, learn to code, and then get a benevolent employer. That's the hell world of America 2017. But it gets worse, because the costs of healthcare keep rising. These costs have been rising since we began recording them back in the 1890s, and they rise faster than inflation. Now, part of that is good, right? More people are living longer with chronic illnesses. Diabetes, cancer, lupus, leprosy aren't the immediate death sentence they were for generations before us. So that's good. People can get better care, live longer lives, healthier and more fulfilling. But a lot of that cost increase is because hospital CEOs and pharma companies, think for example of our friend Martin Shkreli, find ways to charge more money for the same services, or rack up fees for unnecessary services. And no private insurer, woe to them, can stop them, right? Here's how that shakes out. The average procedure in the US costs 40% more than the exact same procedure in France, just because the literal sticker price is higher. Over a third of antibiotics are unnecessarily prescribed. That's bad because that's a lot of medicine, a lot of money being spent on antibiotics, but also when too many folks take antibiotics, diseases get stronger and then come back to bite us in stranger and more challenging ways. But most egregiously, think of MRIs. Y'all know what an MRI is? MRI is a machine that prints money, basically. It's a giant money printer. And here in the US, an MRI costs 5 times what a procedure costs in Australia. Same machine, same procedure, push button, get MRI, 5x the cost. Now this scares the bejesus out of everybody, particularly the payers, right? Now payers are interested in finding ways to mitigate these rising costs. Sometimes that means refusing to pay for claims. You've all heard those horror stories. Maybe it's happened to you. Before the ACA, it meant that payers would often refuse to cover people who were, or who were likely to get sick. That's how you all know the phrase pre-existing conditions. But still, this wasn't driving costs down, so we all got together in the 70s and invented the idea of consumer-driven healthcare. That's the idea that you should make consumers, which is just libertarian for saying people pay more of the costs of their own healthcare, right? Because by making people pay more of their own costs, that'll turn them into smart shoppers for some reason, right? Now, through the power of the free market or whatever, they'll like shop around and not get unnecessary or too expensive care and like yelp their surgeons or something. And all of this together will somehow drive prices down. It's bullshit. All of this builds this atomized, isolationist, and honestly pretty lonely worldview of what healthcare is, what healthcare can be, and what healthcare should be, right? It treats being sick or being poor or being able to get pregnant as a kind of character flaw. It means if you get hit by a car, or you give birth to a premature baby, or you get rabies, you're on the hook for your own costs because it's your responsibility, right? Because paying off your health care is a matter of personal accountability. And if that accident, or if that illness, or if that pregnancy forces you into a lifetime of crushing debt or medical bankruptcy so that a hospital, a pharma company, or your insurer can turn a profit, well, tough shit, man. That's your fault. Should have been born rich. It's a bleak worldview, right? Well, here's the thing. We know it's a big load of horseshit because people who are forced to pay for their own healthcare costs just don't seek healthcare. And I don't mean emergency care, I don't mean end-of-life care, I mean they don't get primary care or preventative care. Because we demand they bear the burden of expensive healthcare costs, people turn their bodies into ticking time bombs, right? They ignore that, like, growth. They ignore that chest pain, and then eventually they have a heart attack at their jobs and leave their kids behind. Consumer-driven healthcare only serves the people who seek to extract profit from our bodies. And so every single year, labor unions are forced to fight corporations for worse and more expensive insurance instead of being free to organize around better wages, better contracts, and workplace safety. So what do, right? How do you square the rampant increase of healthcare costs with the fact that insuring sick people just isn't profitable? Well, if you're the Democrats, you collaborate with the Heritage Foundation to offer us the Affordable Care Act, which is basically the massive subsidization of private industry with public money. It's a wail, it's a plea, please, pretty please, don't kick sick people off your insurance plans. That doesn't work great. Now the ACA had successes, right? Medicaid expansion being foremost among them. Medicaid expansion in the counties which chose to expand it resulted in a 6.1% decrease in mortality rate. That's 11.1 decrease mortality rate for people of color. Now, obviously, these problems that exists because people of color and poor people and people otherwise marginalized were hurting more under the existing healthcare system. But the simple expansion of Medicaid to those folks had massive, if wholly incomplete, effects. So that's good. The ACA normalized the idea that denying someone coverage because of a pre-existing condition is cruel, or at least normalized it among folks that get to be on TV. I think everybody else was able to intuit that pretty easily. And the ACA defined the idea that of essential health benefits, which compose a minimum standard for coverage. Paying a quarter of paying like 25 cents of someone's $1,000 medical bill isn't adequate insurance, isn't adequate coverage. But at the end of the day, costs keep increasing, quality of care stagnates for the most vulnerable among us, and 28 million people are still uninsured. The ACA has failed in its pursuit of health justice. So instead, we demand a federal, universal, single payer. A single payer is a relatively simple concept, right? Instead of having a bunch of insurers, each with their own fragmented customer bases, each seeking to kind of pass the buck and avoid taking care of unprofitable sick people, we have one publicly owned, publicly financed, publicly funded insurer with a legislative mandate to cover all people in full for all their care. Everyone benefits when accessing care is affordable and easy, because delivering care, right, being a doctor, being a nurse, being a therapist, that's difficult. Paying for it is relatively simple. And in fact, we're already paying for it. We're just forced to spend that money really, really stupidly. American public money already pays for 2/3 of all healthcare costs in America. Now, half of that 2/3 is direct spending on Medicaid, Medicare, and the VA, and the other half is government subsidies to private companies. The remaining third just comes directly out of your pockets in the form of premiums or income taxes. And so the goal is not necessarily to reduce spending, right, but to reallocate it to take care of everything long term. We know that Medicare negotiates much, much better prices for treatment because it has 44 million people nationwide instead of a few hundo-thundo in a given state or a few 10,000 in a given county. So you scale that idea up, right? You've got an improved Medicare for all that guarantees fair prices for care nationwide. It's a monopsony. Because they are the single payer, they get to dictate what they're going to pay for a given procedure. Providers then get in line because they either have to accept that or accept nothing. And what providers lose and like that in planned sticker costs, they make up for in volume, because now everybody that comes into the doors will have their care paid for. And so what do, right, with the money saved? Well, we just reinvest it. We use it to improve everyone's standard of living. You build primary care clinics in rural areas. You fund community health centers in poor neighborhoods. And you reinvest the money back into the folks that are providing the care. Y'all know home health aides? And y'all, if you ever had like a sick parent, or like a sick sibling or a sick kid who needs like long-term care or needs care, but isn't sick enough to be in the hospital, you can have somebody come to your house who can perform a level of clinical treatment in the comfort and privacy of your own home. That's good for a bunch of reasons. One, being in the hospital is really fucking expensive, about $10,000 a day. Home health aid charges about $135 per visit. Two, it's more humane because you're not stuck in a sterile like ward, not in a hospital bed somewhere. You're at home where, like, I don't know, your stuff is, which is a whole lot nicer than being in a hospital bed. Everybody benefits, care is more humane, more efficient, we save money. There'll be 1.2 million home health aides by 2020. But when I say everyone benefits, I don't mean the aides themselves, right? Because they're paid an average of $11 an hour, right? So we can use single payer to allocate this money to do what the private market won't, which is pay fair wages for care, essential care that helps everyone. Right now, your private insurer only bears the cost of you receiving care right now. Because you're likely to change insurers in the future and eventually go on Medicare, they don't actually feel the pressure to provide you with care that sustains you in the near or distant future. Instead, literally everybody else does, right? We all do. We all suffer when our friends and family get sick, and our public money is allocated to care for folks when they get sick, when crises happen, when emergencies happen. Insurers have this fear, right, that if you make getting healthcare cheap or even free to the people that are using it, they might use more of it. And that's really, really hard to make a profit off of. So it makes perfect sense that the same actor that suffers when care isn't provided, right? When people don't get preventive, primary, or long-term care, which is all of us united, represented by the federal government, they should also be the actor that pays for that care in the first place, right? You force them to bear both the costs of providing care and the costs of what happens when care isn't provided. And once that federal actor bears the costs of providing care and not providing care, it can finally be a tool for realizing health justice. Here's how that works. If your people are getting sick and your people are dying because they don't have a place to live, or the places that they live are unsafe, they're full of mold, they're full of pollution, they're run down, they're flammable. I'm thinking of Ghost Ship in Oakland. I'm thinking of the Grenfell Towers in the UK. Then housing is healthcare, right? And you provide housing, you build housing, subsidized or free housing to bring healthcare costs down. If people are getting sick and dying because they don't have healthy food to eat or access to healthy food to eat, and they're getting diabetes or cardiac failure because it's not profitable to sell a poor person vegetables or give them the space and time in which to prepare them, then food is healthcare. And you provide folks with affordable or free food options and the training and the resources and the space to prepare it to bring healthcare costs down. If people are getting sick and dying because they don't have access to needle exchange programs, therapy, or counseling, then rehabilitation is healthcare, and you build addiction treatment programs, which focus not just on like the literal prevention of death, but the entire full-scale social support required to keep folks from seeking opiates in the first place. That's how you bring healthcare costs down. Single payer is only the tool, right? It is one financing mechanism. It is a relatively benign transformation. But health justice is a revolution, and that's the goal. Single payer is the tool which begets the goal, and when we fight for health justice, we all fight side by side, right? Because economic justice is health justice. Environmental justice is health justice. Reproductive justice is health justice. And justice for black lives, justice for trans lives, justice for the lives of immigrants and the well-being of all people, regardless of age, gender, race, or creed, that's health justice. We have inherited a world in which your permission to receive healthcare, capital's allowance that you can be safe in your own body, is dependent upon how much an insurer can extract a profit from you. When people are in need, we waste time, effort, and money means testing, separating the worthy from the unworthy among those who need help. And then we stigmatize them instead of guaranteeing the basic decency of health equity. And for systematically marginalized people, sick people, homeless people, people struggling with addiction, people with disabilities, poor people, pregnant people, trans people, people within the carceral state, women and people of color, well, there's no way for the medical industrial complex to find value in their bodies, and there's always the private prison system ready to receive them for profit. Now all I've really done... All I've really done is name the fight. I also want to tell y'all how we can win. You know how we can win?
Yeah.
Hell yeah, me too. We're just told this is the way things are, right? And that, in fact, this is the way things have to be. We are told that universal health care is a pipe dream, and that capitalist, corporatist domination of our bodies and of our health is natural, normal, inescapable, and irreversible, right? That single payer will never ever happen in America. And that's just the Democrats speaking. So, what do? Right? Well, we stand right now on the shoulders of the labor movement, of hundreds of thousands of nurses, and of tens of thousands of doctors who have demanded a clear and focused vision of the future. That insurance is not healthcare, and that healthcare is something a just nation affords all of its people. Now, we've seen this vision written in 2 bills in Congress, one by John Conyers, one by Bernie Sanders, and these offer us the framework from which we can build the broader movement independent of the bills. We gotta be specific in our optimism, right? Like, we live in a pretty bleak timeline. This is the hell world of America. And these bills aren't gonna pass anytime soon. But when it comes time to discuss them, the worst ghouls, right? The worst lapdogs of capital are gonna come charging at us with their fangs bared. And so it is our responsibility to fight. We must build the popular movement, which begins by demanding single payer from our government, and then continues to demand health justice in our nation. And when people tell us that we're bringing about creeping socialism, and that we're rejecting the American capitalist way of life, we say, Yahoo! Yeah. Duh. We keep on fighting, right?
Yes.
Well, that's easy. Well, how do we do that, right? Well, we do that shoulder to shoulder. And I'm a proud socialist. I'm a proud member of the Democratic Socialists of America. And guessing by what y'all just said, I'm guessing quite a few of y'all are too. Recently, our comrades across the country, from Oakland to Buffalo, from Phoenix to Philadelphia, from North Texas to upstate New York, have begun their work of canvassing to build that popular movement for health justice. Now, the idea of the canvas has kind of been poisoned by mainstream parties into this weird, tailorized Frankenstein, or more pedantically, Frankenstein's monster, focused exclusively on signatures and data collection, a bunch of silly, meaningless interactions. That's dumb. Right, that's not canvassing. Canvassing is just talking to people one-on-one, person to person, and it's really the foundation of all solidarities. Canvassing is just a conversation about a shared vision for a better world. And I think there are few more inspiring uses of our time than rejecting the way that neoliberalism tells us to be afraid of our neighbors. By rejecting the idea that we must fear each other by divisions of race, class, age, or gender. And those are just the same divisions that benefit those who seek to profit off our healthcare. If that doesn't make sense, then they say, let me put it like this. How many of y'all have ever been, or know someone who has been, denied health care you wanted or needed because of a lack of funds or access? Cool, keep those hands up. How many of y'all ever seen someone you love suffer because they couldn't afford a doctor's visit, a prescription, or a surgery? How many of y'all want something better? Great, congrats, I just canvassed you. And I'm just radicalized you as my brothers and sisters in the fight for health justice. That's literally the foundation of all canvassing, right? That is how you build a popular movement. In the 1880s, universal health care in Germany was fought for and won by socialists and unions. After World War II, reconstructing a country, nations found the political will necessary to build single-payer or universal health care programs. But right now, we live in the post-Reagan era. Our unions have to spend their time fighting for worse and worse insurance. They don't have the ability to call nationwide general strikes. And so, where they cannot do the work, we together must, and build a popular movement that forces this question through and demands accountability from politicians who might snake out on us otherwise. Now, our friends across the country have been putting together various kinds of single-payer canvassing programs that can be adapted or adjusted to whatever ends are needed, right? We've got resources, we've got tools, we've got training. If you don't know how to go door to door, we have folks that will help you. If you want to build a cannabis, we will walk you through every step of the way should you choose to pursue it. We will provide you with materials, advice, and friendship. But the shape of the campaign, should you choose to fight for it, is up to you, right? All I think the DSA insists is that you start with a deep conversation. Talk to somebody and ask them what they want for the future. What you do afterwards is entirely up to you. Some places, like the New York City Socialist Feminists Working Group, have decided to include Medicaid enrollment in their health justice canvassing. Start with a conversation, and by seeing if a person's eligible for Medicaid or CHIP, enroll them right there, give them resources for clinics in the neighborhood. Some places are deciding to pressure local electeds to endorse Conyers or Bernie bills, usually larger chapters that have a bit more leverage over regional candidates. Some folks are even putting together a Grover Norquist style, bless his heart, pledge for candidates to support federal single payer. In Ann Arbor, they're working on doing ACA enrollment and helping folks identify free or low-cost health services in the community, which have been made inaccessible through the slow trudge of the private market. Now, all these different things are important to me because while the fight is national, like I said before, healthcare and healthcare justice needs are local, right? What health justice looks like here in Indianapolis is different than how it looks in Cleveland or Milwaukee or Houston or Phoenix or the East Bay or Pittsburgh or Albany, wherever. These are regional specific needs. And so I come to you not only as a speaker, right, but as a student. I'm on this road trip to go around the country talking about single payer and what it means, but I need to understand, and I want so badly to understand, how that manifests in the hearts and minds of people across America. So please, for a couple of minutes, talk to me. When we organize, right, we build national solidarity, and we carry our own needs into the fight, but also the needs of all those around us. As I speak on behalf of single payer nationwide, I want to carry y'all, I want to carry Indianapolis in my heart, alongside all the other folks that I get to talk to, so I can understand what we are fighting for from coast to coast and plains to Gulf. I believe entirely single payer is inevitable if we make it inevitable. I believe health justice is inevitable if we make it inevitable. And I am so, so proud to stand shoulder to shoulder with y'all. Solidarity now, solidarity forever, solidarity, y'all. I go around and talk to folks. I know I can give a little 20-minute spiel because I know there's a whole lot of questions either about policy, about what happens next, about how things look, about how healthcare works. I am your tool. Please ask me whatever I can so that I can help you understand what you want to understand. Can someone run staff for me? I just point to people, I guess.
Yeah.
Let's start. What's up?
I was wondering, based on like the more inflated like medical costs right now, say you get like a Medicare style cost for the entire market, it brings it down individually. You said public money right now pays for 2/3.
Right.
Would we be like looking at net no change like for you and me? An outlay, like as far as like the money that we would contribute.
Right. So you're like ultimately, what is your net contribution to the entire thing?
Wouldn't you be driving one side of it so far down, and then so much public money in there already? Like what?
Your net, our best estimate right now is that you pay less ultimately, right? Because right now, what you're doing you're paying the public money, but also you're paying premiums to an insurer. Right. Premiums are higher than they would need to be in a single payer market because that insurer is terrified of covering sick people. So you take that premium, you get rid of it, and you put it in payroll tax, much more than the employer. Ultimately, your costs as an individual go down. And through that process, everyone also gets covered together. It's pretty incredible. Things are just so broken that that's the way that it works out.
Yeah, I would feel like, that's an appealing point that, to be made to me. Like, you're not going to pay anymore.
Mm-hmm. There's this like whenever like somebody I don't know if y'all know Randy Bryce, the candidate up in Wisconsin. He's from my home, which is Wisconsin. He's also a divorced dad, so he's basically just same as my dad. When he goes on TV talking about Paul Ryan's bullshit and single payer, people are quick to say, "Oh, it's a $32 trillion cost over 10 years." But here's the thing: like we're already paying. Like if we paid the same amount we pay now, if everything was frozen in time and costs weren't increasing, we're paying $3.1 trillion a year as it is now. If things don't change at all, and Trump has passed an executive order which is going to change things pretty quickly, that's going to go to $4.7 trillion in 10 years. So the single payer in and of itself saves that $15 trillion just by existing and keeping costs where they're at now. and your contribution, instead of going to an insurer that wants to fuck you over, goes to a single payer that wants to take care of everybody in fantastic. Kind of a branch off of that. One of the things that I talk about, I see there's a chalkboard. I used to be a middle school teacher, so if I see a chalkboard, I gotta draw on it, right? That wasn't a very good one. The cost curve, right? You kind of got like this parabolic effect. This isn't the scale, right? You got like 5% of folks kind of represent this amount of cost, and you got like a bunch of folks that are really sick, folks that are going on the line. And then here's folks that generally don't say no here. What single payer does is it shifts these costs to be a little bit more flat. So all of a sudden you've got people down here who can go see a doctor, can get a shot, and get that thing checked out. You push the costs down and spread them across more people. That's the idea of primary and preventive care. You spend more early to avoid spending more later, right? A good example is, ovarian cancer. Stage 0 ovarian cancer costs change from state to state, but I think it costs like $4,000 to treat at inflated price, treat ovarian cancer at stage 0, and up to $180,000 when you get stage 3, stage 4. So even if like everybody has ovarian cancer and is not detected right now, the obvious like change in cost for a given person's life cycle is dramatic and obvious, right? You save $100,000+ by getting folks screened for things earlier. Also, it's better quality of life. That's why people are so gung-ho on primary and preventive care. So we know we can catch a lot of things early. Now, not all things. There's a bunch of broader questions around if you catch something early, should you necessarily like do surgery on it right now? No, probably not. Watchful waiting is pretty good. We don't want to like rush folks into the hospital sooner, but catching things early lets you build treatment plans, lets you build care programs, lets you build care management, and that's better for everybody in like extremely obvious ways. Now, a big chunk of that is that hospitals have been aggregating primary care clinics over the past 20 years because hospitals have one function. Their one function is to fill all the beds they have in the hospital. It's this thing called Romer's Law, after some dude who was working on Social Security in the 60s. If a hospital builds a bed, it will be filled. The actual demand of healthcare services is entirely irrelevant. If a bed exists, it will be filled. And that means, and you see these things kind of vary from hospital to hospital. I'm sorry, I'm going way off topic on your question, but I'm having a great time.
You're right.
And that varies from hospital to hospital, right? Like, there was a really famous study in Vermont. Vermont is a cool place to study because it's relatively like homogenous from county to county. Like income, age, race, gender differences are all pretty much the same. It's the Netherlands of America. And so you would presume, because people are getting sick at the same rate, they've got the same backgrounds, there's no like massive Superfund sites in one region of the state, that healthcare utilization, how often folks get surgery, will be the same. Not at all. Tonsillectomy rates vary by up to 7 times in neighboring counties, entirely based upon like who the doctor is at the hospital, how many beds the hospital has, and whether that doctor likes tonsillectomies, right? Because healthcare is as much an art as a science, and is influenced by things like marketing, by cognitive biases, and by like doctors' preferences. Where's it going with this? Well, it seemed pretty important. Hospitals like understand that, and so their goal is to to get as many referrals inpatient as possible. And what we've seen over time, maybe it's happening here, I've been curious in this, is that hospitals aggregate smaller clinics and shut them down, making the hospital where you go if you have to get care, right? The reason folks go to the ER when they don't have insurance and feel sick, because that's the only place they can go. Single payer, by forcing single payer to bear all the costs, if things stay the way they are now, and folks just go to the ER when they get sick, single payer, the government is on the hook for a lot of money. So single payer is then forced, the single payer program is then forced to begin rebuilding those primary care programs, rebuilding those clinics. And it's literally happened in Maryland. Western Maryland, the Appalachian region, is almost entirely covered by Medicaid, right? And Medicaid is both the state and a federally funded joint program. The state pitches in, the feds pitch in. So therefore it's a lot more cost sensitive because the state's on the hook and the state has less money in general. So Medicaid, which I think is one of the best programs in the US, it's being abused horribly, but like in general, like Medicaid's goal is to provide as much care for as many people as are permitted to be within it. The permissioning of who gets to be in Medicaid is pretty horrendous. Means testing sucks. But like the Medicaid director themselves is usually like pretty chill and wants to do a lot of good work. Back in, I think it was 2011, I think Shannon McMahon was the Maryland Medicaid director, no relation to the WWE McMahons. And she realized that in Appalachian, Maryland, there was just one hospital and a bunch of folks that could only go there for care. And it was all being paid for by Medicaid. So folks were getting sick and not doing anything because they couldn't go anywhere. They go to the hospital like when things were way too serious, and Medicaid kept getting squeezed. So here's what they did. Here's what a single payer can do. Medicaid told the hospital, this isn't working out. This is not a great thing. We're going to pay you a flat rate for the year. We're going to pay you $100 million, no more, no less. Make your own profit. You got to cover everybody. Can't turn anybody away. Here's your flat fee based on the past couple of years. Go forth and invent your own profit. So what do the hospitals do, right? If the hospital is being paid a flat fee, any surgery it performs that it doesn't need to perform is then a cost to the hospital. If it's required to cover people in order to reduce its costs, it then went out and rebuilt the primary care clinics that it had shut down over the past 20 years. So doctors are in the communities, and so if you feel sick, you can go to like the local PCP, see what's wrong. If there is a big problem, go to the hospital. If not, get earlier care sooner. It's obvious, right? Like that's literally how it works. That's the thing. That's the kind of reform a single payer is compelled to make out of self-preservation. I think that's. I see your hand. Yes, ma'am.
So why is it that Medicaid doesn't have the bargaining power that Medicare has?
Great.
I mean, because 50% of the babies in this country are born through Medicaid.
Mm-hmm.
That's half the population that's on Medicaid as a child, right, from day one. So that's a lot of people. So why don't we have the kind of bargaining power that Medicare has, as you were?
Great. So there is one federal Medicare program, but Medicaid is a state program. So you got 50 individual Medicaid programs. And on top of that, like because Medicaid goes to people that are in need, like in America, we love to determine the worthy from the unworthy, needy, right, and find ways to put it over. Who is eligible for Medicaid really varies from state to state. For example, in Alabama, you got to be actually from Texas, which is my second home. You need to be making less than 50% of the federal poverty level, so $7,000, and be either disabled, blind, or pregnant in order to receive Medicaid benefits. So, like, we find ways to. So, the reason so many folks are born under Medicaid or born under CHIP programs is because Medicaid has a carve out for pregnant people and early poor kids. Like the kids themselves aren't poor. I mean, poor children are poor kids. Because we realized that like having this big patchwork program leaves a bunch of folks entirely under the bus. And in the 90s, we recognized that like maybe letting kids grow up without health care is bad. So CHIP was passed. Although CHIP is now on the rocks, that's pretty cool. So that's why. But you've got a bunch of individual state programs with really limited budgets. Also, Medicare is the agency that sets the prices nationwide, right? So Medicare has this committee called the Rules Update Committee. Actually, this is pretty fun. Medicare says, okay, we're gonna like build a schedule of how much we're gonna pay for a given thing, right? So you've got surgery X, Y, Z. X cost, let's say X is a knee surgery, that gets 1 unit, Y is a heart replacement, that's 5 units, and Z is a Band-Aid for your finger, that's 0.025 units. At the end of the year, Medicare gets their budget and says, okay, 1 unit is worth $10,000, and then rolls that out, and that's nationwide. And providers have 2 options, either they accept this, or they don't accept Medicare at all and lose all that money. Because providers can't afford to lose access to 44 million people, they adopt this. They then take these rates and use this as the basis for charging your insurer, right? So your insurer has to pay, depending on the prestige of the hospital, between 2 and 5x what Medicare pays to cover an insured person.
So there are some dollars, though, coming from the federal government, right? Because they're talking about cutting those now to Medicaid, to our CHIP program, for example, or our HIP 2.0 program. Is going to be block granted to us from the federal government. So there is some federal involvement.
Right, it's federal state match.
But they're not bargaining for us.
They're not. Because the Medicaid agency is a state agency. Medicare is at the federal level. Medicare can act on behalf of 44 million people. Medicaid is acting on behalf of however many people have to be in Medicaid in the next state. So Medicaid does negotiate prices with hospitals in the state. Often they negotiate much lower prices than what Medicare negotiates, but the result is that because they are smaller and they are covering people that often are in more need, hospitals have a lot more leverage to push them around. Or honestly, you see what happens in a lot of poor areas, hospitals or providers say we don't take Medicaid patients. You have the one dentist who just DAs teeth and nothing else.
Which is very common, like in Indiana for pediatrics and dentists that many providers won't accept Medicaid because they can get away with it,
Right.
and Medicaid isn't paid a whole lot anyway in Indiana, most places. But I think the fundamental difference is that Medicare is federally administrated, so there's central administration, whereas Medicare is federally administrated. Medicaid is administered in each state, so it's balkanized.
These
Even
little
though half the money
laboratories for democracy are really great, aren't
What's
they?
that?
Little laboratories for democracy.
Right.
A different way to say, how does the local people protect the profits of their local people?
Right.
Let's call it
What
what
like
it is.
Medicaid, so you've got like as far as like payment structures go. I got to talk for it. I got to keep using it. Medicare pays at this level, Medicaid pays at this level, and like your private insurance pays at this level. Like if ultimately our single payer pays at this level, but all 300 million people have access to care, well, that's fine. That's a good thing to have. That way, like the goal of single payer is that everybody's in the exact same system. Right now, you've got like these multiple tiers of how healthcare is offered. Right? If you are a jillionaire, you can get a free heart or like a heart transplant from the Cleveland Clinic. And the heart almost always comes from an uninsured person. Literally, your body, if you aren't insured, is like the canvas where people get to paint upon. Like you've got like care for like the ultra wealthy, care for folks with good private insurance, care for folks on Medicare, care for folks on Medicaid, and everybody else. You've got like 5-6 different tracks. Single payer forces everyone to be in the exact same risk pool and therefore receive the same kinds of care. So we are incentivized. Because you want to because now this federal single payer is accountable to all these 300 million people to make sure that the quality of care is appropriate. Because everybody has equal standards in the system. One of the things that Medicaid does do well, and this is important to acknowledge, like one of the few benefits of as a pizza, it's really exciting. It's obvious. But one of the benefits of Medicaid is that like. Because healthcare needs are so regional, you do want to have a state actor involved in administration. But the problem with Medicaid is that you put states on the hook for financing it, and that's where all this shit begins to bungle, right? Like, it makes sense that, like, somebody in, I don't know, like a Medicaid administrator, like, in Indiana knows a whole lot more about how Indiana looks than somebody in New York or Sacramento. Right? And so therefore, like having a state-based administrator is a thing that makes sense. But when you make states pay for healthcare, when you make states pay for Medicaid, you open the door to a lot of problems. This actually kind of ties into the question of like, why do federal single payer as opposed to state-by-state single payer? States are constrained in how much they can spend in a given year. In like the 80s, for some reason, I wasn't quite alive yet. Maybe I was, but I wasn't aware of it. A bunch of states passed balanced budget amendments, which dictate that a state must only spend what it receives in taxes, right? So if at the end of a year, so a state can only spend what it receives in taxes. Healthcare is countercyclical. If you're most folks, healthcare spending is countercyclical. When people lose their job, they tend to need healthcare more, right? So if your primary financing mechanism for a state-based healthcare system is income tax, when folks lose their jobs, they need healthcare more, but you have less income coming in, so it kind of hosed over. Because states can't deficit spend, they got to cut education programs, or road programs, or subsidies of power companies, or whatever. And that's a tough spot for states. They've been made inadequate to handle the problem. At the federal level, you don't have those kinds of problems. One, you've got things like the F-35, a plane that doesn't work. The Sea-Whiz, a gun that can't shoot. It's my favorite military project, the Sea-Whiz. You've got the ability to deficit spend and attack the 1% and like capital gains tax, and also you can print money, right? Like there's fundamentally this austerity level understanding of how income and economics work on the federal level that isn't quite right. Like even Alan Greenspan, bless his heart, pointed out that like Social Security has never really been at risk because worst case scenario, like the U.S. can always print more money if there is some sort of catastrophic event and income isn't there. The feds can do that, the states can't. The feds have a lot more tools than states can. So when a federal government cuts grants to Medicaid, states really feel it, and they've got to reduce their spending. That's why you get this like fucked up hell world where people are squeezed and drained. Any kind of Medicaid reform being offered right now is pretty hosed. Does that kind of answer your question? Did I get through there? All right, let's go to you and then.
Yeah, I just had two quick things. One is just kind of something I'm interested in. I feel like a lot of people that I know in recent years have utilized urgent care type facilities a lot. Where would those type of things exist within the single payer framework, or are they kind of a byproduct of they know that there are a lot of people who just won't go to the emergency room?
You're onto it. So urgent cares are
you would need them ideally if there was health justice, more like you were saying.
Right. Urgent care has popped up after primary care got gutted, right? Now that hospitals have, it's really a huge problem in New York City. I know it's a problem everywhere, but like there, you can like point at a map and say, oh man, there used to be like fucking like hospital, there used to be like doctor's offices in all these blocks, and then they were gutted, annexed, aggregated, shut down. And so all of a sudden, like there's no healthcare provider, so urgent care, which is usually like privately run, is put in this place to kind of fill that gap. Urgent care is fine. I use it all the time, right? Like I get bronchitis twice a year for some reason. And I love going to urgent care instead of the hospital. But like that kind of model of like, here is a cheaper place to go for low urgency care is the same thing as primary or preventive care. But where primary and preventive care differ from urgent care is that they're more comprehensive and treating like a bunch of things that happen in a person's life. I got a couple of cool examples of what primary care, like urgent care is like, I feel sick right now, I want to be alleviated, and like the urgent care center looks just at like immediate clinical treatment. You are sick, you need antibiotics. You need a shot, here is a shot. You got a weird cyst, we're gonna pop that cyst. Primary health is focused on more than just like immediate, like handle what's happening right now. And you can do a lot of things with those programs. I'm talking about this idea of a medical legal partnership, which is a kind of a primary healthcare clinic that's opening up in Boston. I'm super amped on these things. We understand that people have a lot of civil protections that they don't access, right? Why don't access it? It's fucking hard. I love being online, but there's so many forms to fill out if you want to get like the things you're entitled to as a citizen of the U.S. that people just don't seek it. And so a primary care clinic brings together like healthcare, clinical care, and legal protections. Here's how that manifests. Say you bring a kid to this clinic in Boston, and you say, my kid's got really, really bad asthma, and my kid is 2. This is way too young for the kid to have asthma this bad. The person takes you in and says, okay, let's go through. Okay, here's like the doctor or the nurse will take care of you. Here's a little things. But also, like, what's your home like? Like, where do you live? And maybe the person says, and people have said, oh, I live in a slum, and there's mold in the walls, and there's like a giant rat that barks at me when I walk into my apartment because I don't have a lot of money, and so therefore I'm fucked around constantly about my life. Well, that's technically illegal. You can't do that in the US. But how do you access a lawyer if, like, you have to spend the rest of your time, like, working on a minimum wage job and taking care of your kid who's sick? That's why there's a lawyer next to her. The lawyer walks in and says, here's a letter to your landlord threatening to sue them. I will check back in a week to see what happens. A lot of the problems that kind of cause these long-term conditions, there are protections for, but people don't have the access to all these different kinds of care. So primary care centers focus more on expanding these different kinds of programs to address these social determinants. There's a really good primary care clinic in Arkansas that has, like, I was talking about like food, that kind of stuff. It's the home of intensive cardiac rehabilitation. Little Rock is a giant food desert. So this primary care clinic, there's a couple of them across the city, like have kitchens, have cooking classes, have well-lit spaces, have big free social events where you show up, there's a big cooking class, they give you food, you bring it home. Like that's how they're attempting to address diabetes, which is causing a ton of cardiac failures all throughout the county. That's these kinds of programs that exist, the idea of case management, of bringing in all these strands and treating them like at the point of care so that you don't have to go hunt them down yourself as a person, is where primary care, which is generally like not-for-profit, differs from urgent care, which is just like see, touch fuzzy, get dizzy, like see sickness, give pill, see flu vaccine form, give flu vaccine. Does that make sense?
Yeah, but is there any reason that under single payer that type of I feel crappy right now and I want to not feel crappy anymore and you just go someplace with, because anytime you hear anything that isn't the status quo, right, the argument is always, well, you're going to have to wait forever and you're going to die, which of course isn't true. But I mean, would there still be like a place that you're like, I'm sick today and I can go?
Yeah, absolutely. Because you want to do that. Because if people are sick today, you want to take care of them today. Because tomorrow they could get sicker.
Yeah.
I just think that a model that is more focused on long-term care includes
would help avoid that
care with inside
as much as you need it.
Russian nesting doll of other kinds of care that are essential. That's the goal. But yeah, a question on wait times is good. People love to say wait times whenever we talk about universal health care. In the U.S., we have terrible wait times. We just don't record them. And for a jillion people, wait times are infinite. And for others, a mighty long time to wait for any kind of care, right? We have limited information on wait times in the U.S. I do know some things off the top of my head. One of them is pretty obvious. If you're wealthy, your wait times are zero. Because you can do whatever you want if you're rich in America. For everybody else, wait times in the US are pretty on par with the rest of the world. Some places are better, some places are worse. I know Boston and Los Angeles have wait times for cardiac treatments that are like just in line with the rest of the world. The one big difference, this is where they always come back to, is orthopedic surgery, right? Knee replacements, hip replacements. In other parts of the U.S., in other parts of the world, like Australia, for example, the government has put together like a tier, or a tiered list of different kinds of surgeries. At the very, very top, you've got things like heart attacks, strokes, pulmonary embolisms, like contagious illnesses, HIV, all these things that are kind of prioritized. Tier 3 and Tier 4 are things like orthopedic surgery, things that are important, but like if you don't get this right now, you're going to die. And so therefore, Australia has invested a bunch of money into addressing making sure like Tiers 1, 2, and part of 3 are like immediately accessible. That leaves like kind of like the orthopedics and a little bit of a gray zone. It's not great, but it's understandable. So here's what happens. Australia had their own little like mini Tea Party revolution. It's the Tea Party, mate. In like the early aughts. This is the thing that they hammered. Australia developed this weird like splinter cell private provider group that got federal money for some reason to address this problem. Like, oh, okay, well, like, because wait times across the board, because they conflate one for being everything, are so egregious, let's put it in the private market. And it turns out, if you are a private, like if you and I and all of us become doctors tomorrow, we're going to go open up various clinics. If we open a primary care clinic tomorrow, we'll go broke by the end of the year. It takes a long time to give good primary care. It's not compensated very, very well right now. And it's like low volume, right? Unless you want to like pump people in and out like a factory, which results in misdiagnosis. If we were to open up a really, really intensive like heart replacement clinic tomorrow, we also got to it's high margin, but it's pretty low volume. The one thing, if you're a private provider, you can make a shit ton of money on is knee replacements, hip replacements. And so what do you know? The private market was like, we could take care of this entire problem by ourselves in Australia. And we just ended up providing knee and hip replacements to wealthy people through their special like fielded clinics. So like that is like how the wait time battle shakes out across the rest of the world. By and large, like wait times for essential and immediate care are reasonable and can be made more reasonable in American single payer compared to
Can I break it for a second?
Yeah.
So it's 8 o'clock, I think. How are you feeling on time? Are there any, I guess, show of hands, how many people still have questions? Let's see. 1, 2, 3. Anyone else? You had your hand up. This is 4. All right. You want to do like a quick.
Now I'll keep going for as long as
Okay. Well, let me start a stack then, I guess. So who got their hands up first? I think it was. I want to say it was Brian and Joe. I think. I'm not sure.
I think she actually.
Who had their hand up?
Kate.
Kate. Okay. Yeah. Go. Okay. Sorry. So.
I did too, but yeah.
Okay. We'll start with Kate and then we'll go around. Right there. Okay. Yeah, sorry, I'm just. Yeah.
That's okay. So you want me to ask my question?
Yep.
Okay, so it might be a stupid question, but like, in a single payer situation, what would happen to all the pharmaceutical companies, and how do people pay for their prescriptions?
Cool.
And what does that cost to look like?
Cool. Let's answer those questions in backwards order. Under Bernie's bill, there is a max on one of the founding ideas of a single payer movement is that all costs for all care for all people are covered entirely before. Pharma is like the one parenthetical. Right now, Bernie's bill has a max out-of-pocket limit of how much a person can spend of their own money of $250 per year on medicine, which is much better than we have now, but it's still too high for me. One of the ways that single payer would address pharma prices is just by literally letting it negotiate. Right now, Medicare isn't allowed to do this thing for
That's an
for
important
drug
point
prices.
because we're talking about Medicare having all this leverage, but by law, right wingers are made it so they can't
But they can't
negotiate
for-
drug prices.
Okay.
Right. That's only because the law says they
They
can't,
said
right?
Yeah.
the decision that was made.
Yeah, that the act of passing single payer would repeal that. Right now, like that's why you have things like reimportation bills, because we presume the will doesn't exist to actually let Medicare negotiate for drug prices. So instead, let's reimport them from Canada for some reason. A single payer must be permitted to negotiate those prices of care. Ultimately, like what I want personally is the nationalization of the drug industry, because the drug industry just takes research from public institutions and then turns it into profit. which is generally opposed. But like the thing the pharma companies are really, really good at is inventing new kinds of diseases and marketing to doctors about those kinds of diseases. Like Viagra has created, like, it's fine, way to go Viagra, thanks Bob Dole. But like that was a pill that was invented to create a problem which then could be solved. Instead of focusing on things that treat more, that affect more people and help people more broadly. Right now, because people can't negotiate with pharma, except for insurers and like the Coast Guard, the VA, the Indian Health Service, and the Department of State, they can bill too much money, which forces state Medicaid programs into weird spots. A good example is the hepatitis B drug. Washington State, hepatitis B is a comorbidity of opioid addiction, because it can be shared through needles. It tends to happen that where opioids are a bigger problem, Hep B tends to fall behind. Washington State has a pretty robust Medicaid system, but it was being charged $80,000 per course of treatment for hepatitis B drugs. And then began trying to cut off access to that drug. It was sued by my girlfriend. And was forced to cover all people, but like that's kind of the kind of problem that exists when you don't let the state negotiate drug prices. You want full monopsony, which is full like single buying power on all fronts, and that's included in various economic schools. Having that limited like out of pocket max is way better than we got now. That's still like for some folks $250 a year is still a lot, particularly if you get a lot of drugs. That exists so that you can provide an incentive to folks. If there's two drugs that are available, one's a brand name that costs $1 million, one's a generic that costs $1. You put a cost share on the brand names, so people are less incentivized to go to the generic. But I think you can just structure your formulary to cover the generics in case of an emergency, but that's a bit wonky. But the goal is, yes, more drugs are covered. Maybe you have to pay a little bit, but by and large, you're not on the hook for like tens of thousands of dollars a year. Answer your question?
Yeah.
Tim, I have a follow-up question for that. I mean, how realistic is we're going to nationalize big pharma?
Well, that's my goal. That's not the goal of single payer.
Well, I'm just saying, is there any other possibilities besides nationalizing them? I mean, like, for example, Japan has drug price controls.
Right.
Now, some could argue they've kind of gone too far. But in any case, they control the price of drugs. They just put a ceiling.
Well, that's what single payer is. Single payer says we will pay this much for this drug. If you want to sell the drug, you take this price. If you don't,
That doesn't require nationalizing the
no. That's like my like.
Okay.
They are a parasitic
Yeah.
organization. We should be.
Yeah,
Yeah.
We're in complete agreement about
Single payer, by the power of having like the only buying power, is a price regulator because either you set that price, you sell at that price, or you don't sell it. And drug companies, even though they're going to complain, are going to sell if there's only one person offering to buy that drug. And then that is like the lever that's still there. It's a de facto price regulation by setting the price.
I just had a few comments just about Indianapolis. So I'm a physician here in Indianapolis. But just some unique things about Indiana. So you were talking about, of course, like the profit margin in orthopedics, and also hospital beds, getting filled. So Indiana's unique as one of the states where we don't have a certificate of need. We don't need to have a certificate of need in order to build a hospital. And so we have hospital systems that in central Indiana, but all across the state, just building hospitals left and right in profitable areas just to make money. And so we have. So I work for IU and also have a VA appointment. But so we have IU, and then called the Community Health System, which is another set of hospital systems, St. Vincent's, St. Francis, 4 hospital systems. And they'll build hospitals right next to each other. So up in the north side of Indy, in Carmel and Fulton County, which is very affluent, they've built new hospitals right next to each other just because, well, the rival's doing it, so IU builds a hospital, and then St. Vincent builds a hospital right next to them. So it's just sort of one of the unique aspects of Indianapolis. And also point out, mentioning drug prices, that Lilly is the big pharmaceutical manufacturer here in Indianapolis, of course, and they were in the news recently because they were raising the price of insulin, which of course is necessary for people with type 1 diabetes, without which they die. Let's see, what other, I'm sure plenty of other unique things about Indianapolis and Indiana that people can share, but I'd really like to talk. We could probably chat for hours, so I'd be very interested, but my one question was actually maybe opening a too big a can of worms, but I'm a proponent of socialized medicine. And so single payer is not socialized medicine,
Right.
it'd be intermediate step. Would you call that the goal, or do you think that's just not, it's a step too far, like nationalizing pharmaceutical companies? It's further off on the horizon. We should
Right.
focus on single payer now.
So here's my personal opinion,
Yeah.
not
I'm just curious to hear that,
at DSA. I think you look at socialized systems like the UK, like Australia, and then you look at the US. We can solve the majority of our problems by nationalizing just the payer side first. I like the idea of provider. Like right now, as you know, like if you want to go to med school and become a doctor, and you want to work in primary care in a rural area, better hope you're born rich, because you're going to be fucking broke. You come out of med school with like minimum $300,000 in debt, so you are thus incentivized to go for the kinds of care that get priced the highest, right? That's why we don't have a shortage of that's why we don't have like a shortage of hand surgeons, but we have almost no rural medicine doctors, because no one can afford to be a rural medicine doctor. I think part of a socialized system like Cuba or the UK can more aggressively affect how that works, but we can do that here too, right? I think part of a health justice movement, I think embedded within a single payer movement, is things like tuition relief or free tuition for doctors, right? You get more to the idea of like being a doctor, provision of healthcare, not just doctors, nurses, therapists, anybody who provides care, as being a form of public good. I think you can do these things like provide tuition relief, free tuition, and begin kind of like adjusting some of the supply side concerns without having to take on both the provider lobby and the insurance lobby at the same time. And like whether or not from the way I think about how healthcare works in the U.S., I think you can solve most of the problems. You can use single payer as a tool to solve most of the problems in health justice, and the incremental effort of going for socialized medicine doesn't yield the same
Marginal
results.
benefit isn't worth the cost.
Yeah.
That makes sense.
That's my stance.
Next up, Ryan.
So AJ kind of touched on this a little. We're talking about the unique conditions that we have here in Indianapolis and central Indiana. You mentioned the hospitals. There are a lot of them. You mentioned Lilly, one of the top 5 biggest employers in the city. The other one is Anthem Insurance based here in the city. So
They're bad.
So yes, Anthem, terrible. So, like the healthcare industry is probably the single biggest employer in the city of Indianapolis and central Indiana. So, I feel like we're gonna run into a lot of resistance from people if we're trying to mess with that. And that's a lot of people's livelihoods.
Right.
People who work for Anthem, for Lilly, for the hospital. So what do you say to that? People who are worried about what will happen if maybe we don't need Anthem anymore.
That's a great question, and I think I have a great answer. So in both Bernie's bill and like the DSA materials for like what we think which they're pitching this at NBC over the weekend. I didn't write it, but I was a little bit involved, and I think it's pretty good, and I'm proud of it. That's one of the reasons I was talking about is like DSA's single payer pitch, what we want to talk about. One of the provisions in both Bernie's bill in that is fair transition, which is a union policy that developed in oil and gas in the 80s. Bernie's bill calls for 1% of the total federal health single payer budget during a 5-year transition period to be allotted to either rehoming or retraining insurance industry employees who would be laid off or whose jobs would be made unnecessary in the transition. Now, that number is less than we're told to believe, right? I think an estimate that I read of how many people's jobs would be affected by moving to single payer is like in the high hundreds of thousands, but below 1 million. Compare that to 1.1 million people who are laid off or quit their job every single month. Like we had this is not like as catastrophic a change to job structures like on the nationwide scale. We have the resources this isn't like oh my god, everyone's losing their job kind of thing, like the entire GDP is collapsing. It is a lot of folks taken care of, but the money is like being specifically called out to retrain with wells. But also, what I think is interesting is like a lot of the skills that exist in insurance are still going to be needed in a single payer, right? Like the big thing you get away from by having a single payer is the entire function of that sector, whose job it is to say no to things, or to question doctors or push them around. And a lot of those skills are applicable to kind of the like. I mentioned before the idea of a community health center or a primary care clinic trying to find more ways to get folks things to which they're entitled. That is like the mirror image of how folks who are in claims adjudication work now. So therefore, they can be used to fill the same role, right? You know what I mean? Like you can take somebody whose job it is to look at all the claims a person has coming in and say no, yes, fight the doctors, and say, okay, well, now we want to create 1 million more jobs of case managers, care managers, people that find these kinds of protections and steer folks that way. Like I think we're creating a bunch of jobs, and we can take the folks that we're displacing, put them into those similar skill set, and make sure folks are taken care of. I don't think that's actually that ludicrous a proposition. Like that's the kind of job you need to have if you want to make single payer cost efficient. You've got the people, just put them from one to the other, and like they can have jobs that make people's lives better and more fulfilling. I work for an insurance company. Certainly not representing them. They don't know I'm here. And so a lot of stuff comes from things that I look at and things that I see. And there's a lot of folks even that work in insurance that know that what they are doing ultimately harms people. And I think if you offer, like, here's the path through, here's the money to take care of you, and here's what we can build instead, a lot of people will jump out. But also a lot of the administrative work will still exist. Recently, they record health data, put it somewhere. Forgot about it. Like right now, the computer structures which are used to pass claims from hospitals to payers are written in languages that are spoken by like 4 people, and that were written in the 70s. Like there's a bunch of massive infrastructure work, kind of like highways, that only a federal single payer can work on. Like there's a lot of work that needs to be done. We're not throwing people to the streets, and I think it's really, really important that we demand that in a single payer program there's money allotted to take care of folks, because they are labeled like doctors, nurses, everyone else is labeled. That's your question?
Yeah.
Cool.
Alright, so Jill.
I just had a question about something specific you said. You said 2/3 of medical spending in this country is already paid for publicly. Half that's Medicaid, Medicare, and the VA. And what did you say what the other?
Public subsidies for private companies. It's a
Okay.
combination of tax breaks for providing insurance. It's a combination of like directly giving money to insurers. Right now under the ACA, the way that we bribe, well, until this executive order goes through, the way that we bribe insurers, which happened while I was driving, that was a really fun phone call we got. I love my girlfriend more than anything in the entire world, but I wish she hadn't told me about that executive order while I was driving. Boy howdy. Crashing it. It's really bad. A big part of the ACA is just like paying people's insurance premiums for them to the insurers, which is like stupid. Whereas like that's a huge waste of money. Or it's literally like paying an insurance company on behalf of an individual. And then also tax breaks. Tax breaks are a form of subsidy because it is lost.
Okay, and then if I can ask one more question, I think I misheard you. Did you say that Bernie's bill for single payer does provide or does have provisions to retrain?
Yeah, 1% of the budget so Bernie's bill has a 5-year transition program in which like we lower the Medicare age by 10 years every year and also provide the ability for employers to buy into the program. I think it's a bit of a prolonged transition period, but it exists. And Bernie's bill demands that 1% of the federal budget for healthcare is allotted to fair transition, as does DSA's.
Anyone else have questions? Okay, I think she put her hand up first. Go ahead.
Well, go ahead. You have had a question.
Okay. I also work in the healthcare field. I'm a medical student. You probably know about the kind of infuriating system in the VA, at least with like EMRs, trouble transitioning and trouble keeping sort of updated. I think changes in the EMR at the VA need to go through Congress to get updated. Is there any reason to believe that a more nationalized healthcare program would kind of not run into those same problems? Just sort of bureaucratization and inefficiencies.
Right. Because literally it has to, because costs are on one. One of the reasons that we are able to get away, I think, with the status quo is that the problem is spread out among a bunch of individual players, each seeking their own like immediate benefit, not a broader term resolution, right? If all of a sudden there's one payer and it either has to fix its medical records or lose a couple $1 billion year over year, and is compelled to and is incentivized to begin fixing these things. Also, it's held accountable to voters and voting interests. EMRs get better in the private sector. I mean, what's that company up in Madison? Not Edge, Epic. Epic is a material benefit, a material increase over like original kind of claim codes and ways what's the fuck called? The text dollars was passed back and forth. I don't believe that bureaucracy or adding more state or federally run programs necessarily comes with these problems. I think that's in the private sector too. I think this just gives us like the tool to begin looking at them like holistically as opposed to just like making it everybody's kind of shared problem.
Okay. May I address that as well?
Yeah.
So, yeah, I mean, I think that is sort of that's an argument. Yeah. So I have left of center friends that are doctors that say the same thing. I worry about if we had a single national healthcare system that Congress gets excited, so if we have a right-wing Congress, they'll gaslight down all the funding for the programs and everyone gets screwed. Yeah, sure, that's a concern, but I think if there's a nationalized system, then there's built-in constituency that fights against it. Even the ACA, the right-wing Congress couldn't kill the ACA despite trying as hard as they could and having unified control of the federal government. And if we had a single-payer system, I think there's even more constituency built into that. The ACA only covers a pretty small slice of healthcare. That's number one. Number two, so I'm a biased. I'm not an unbiased observer when it comes to the VA, but because I have a VA appointment, so I think the VA actually works quite well. But I think that our metrics we have for healthcare outcomes are really pretty shitty. They're bad. But the VA, with those metrics that we do have that aren't very good, the VA does very well. So people like to complain about the VA. So I don't know what your experience has been. I'd be curious to see who you work with. People love to complain about the government, about healthcare in general. But the VA actually on the crappy metrics we have does very well. And actually veterans, so the patients of the VA, rate the VA very highly. So across the country, patients of the VA rate their healthcare better than private patients do rate their healthcare. And that's also true in Indianapolis. Our VA is highly rated.
I would agree with that, being a veteran who goes to the VA.
Okay.
I'm very thankful for my VA care, honestly, and I've been saying this for years. Why don't we all have this, right? Because Medicare people have it, Medicaid people have it, VA people have it. I mean, there's so many people now who have some sort of
the VA is socialized
nationalized
health care.
healthcare.
So
There's just a small majority of
go.
middle-class Americans paying these outrageous prices for healthcare that don't have it. There's so many of us that have what is a nationalized healthcare system.
People tend to be afraid of single payer until they get Medicare. And like, oh, this isn't that bad. Medicare is even within like Medicare Part A and Part C, which is the privatized this grift program. People tend to like Medicare quite a bit when they have it. You just don't worry about shit anymore.
Yeah.
Medicare isn't the perfect program. You want to improve it.
I think one other point.
Yeah.
So, but there's also this idea that private anything is better, is more efficient than the government, which so right now at IU, I think it's largely bullshit. I think every big organization of people always has problems, right? Electronic. At Med Center here, we have a very large Med Center, so it's been a while now since I was a med student. We've gone through a bunch of different electronic medical record systems, so at Methodist and IU and Wishart and Eskenazi and VA. So I've experienced a lot of them, and none of them really work that great. And so it's not unique to the VA. But our dialysis unit at the university has just been bought by one of the big LDOs, large dialysis organizations. Are you familiar with dialysis at all? So these two large corporations that own most of the dialysis units in this country, Fresenius and DaVita. So DaVita just came in, and they have their own proprietary electronic medical record system that they use all over the country, and they're a very profitable corporation. They have this. So John Oliver did a thing on Ken Fury, who's this crazy CEO of DaVita. This is, 6 months ago maybe, and highlights how nuts this dude is and how DaVita is pretty corrupt and they make a shitload of money. But you'd think as a private corporation, what we're told is that corporations are really lean and they're efficient, but they have a really crappy medical record system. So all my fellow nephrologists and kidney doctors are complaining, not all, but the ones I talk to closely that are friends, don't like the medical record system with DaVita. They didn't show up and suddenly wow us with their efficiencies. They have efficiencies, but they're not efficiencies that really make our lives easier. It's sort of cutting down on care. They have a central lab system, so everyone all the labs get sent to Florida. They're cutting margins there, but it's not. That doesn't help patients.
Right. That's just that is.
They don't care where their drug or where their blood's going to get tested. But it still gets at that idea. So there's a bunch of anecdotal, the VA didn't work well, whatever. But when you look at the big picture, there's always counter anecdotes like this VA experience of mine. But also when you look at the big picture, I think that the VA does quite well. And so books published about it, and you can check out John Oliver's bit about it.
Single payer doesn't mean that automatically and immediately the Fed owns the hospitals.
That's socialized medicine.
That's
yeah.
exact. What it means is that they're going to pay that corporate entity that you are possibly intimating is more efficient than a governmental institution, which I don't buy into, having been executive management at a couple local companies. Business as efficient as bullshit.
Yeah.
But it's a goal, and that should be a goal of government. But the government will not own these private corporate entities, so whatever efficiencies they have to achieve for profitability off of the funds they're being paid will still exist. It isn't a magic of business. It's an intent, a goal, an objective, and an implementation process. That's all it is.
So, just a quick question. Christina, did you ask the question you wanted? Or?
I have a comment. It was just a comment briefly about when you were talking about the kind of the healthcare challenges of our area specifically. And I don't know that this is representative, but it does seem to be coming up a lot in my personal existence and encounters. Is mental health is just not talked about here. I mean, we don't have access. We don't have clinics. We don't have the VA is desperately short of psychologists and psychiatrists. Then, of course, we add to that the epidemic, the opioid epidemic. And so I had a conversation. This is just coming from an experience I had with a police officer here. He's a sergeant at IMPD. And it was just really disturbing because it gives you a very clear picture of what we're up against and how people look at things like mental health, for example. And his attitude was, those people always end up in jail anyway. So there's really no point to treat them. They're going to end up as criminals. He's like, that's what happens to those kind of people. It was so disturbing, right? Here's a man with a gun who's making decisions about the welfare of people's lives on a daily basis that are sometimes fatal, and he, is defending police being able to shoot people indiscriminately in this case, whether they have a weapon or not, based on the fact that they have mental health issues. They're a criminal. They're a criminal. They're going to end up in jail. So it was just, this is kind of something I feel like we have issues in our community of drug abuse, and like 11%, what was it, 11? We have the second highest rate of parental incarceration in the country, in Indiana, maybe in Indianapolis, but in Indiana. So that's, the recent studies I was reading, kids are 8 times more likely if they have a parent in jail to end up in the incarceration system. So they're not getting those support services. They're not getting mental health treatment. They're not getting substance, abuse treatment. They're not getting re-entry treatment. It's just a constant churning of pushing through people through incarceration. So we have a lot of people who are in incarcerated situations here who have mental health issues. They're not criminals. They need medical care.
Right. I have a comment on that, then I have a closing comment. It's like we're wrapping down, or shall I?
How many questions left?
I can just talk briefly about that. I was in a psych ward about a month ago.
Go ahead. Were you going to add a comment to that?
Oh yeah, it's just that there's really almost no other option for mental health professionals in the medical system right now to deal with people who are severely mentally ill. They don't have anywhere to send them.
Yeah, this is a problem.
If they're in emergency care, they just a lot of the cases you kind of discharge them to a halfway house, and from the halfway house they go to the street. Where you sometimes have to discharge them straight to the street if they failed out of halfway houses before, but kind of use up the resources in the area. I live right by Methodist, so I usually walk that route. I'd see patients that we just discharged the other day, homeless on the street right next to Methodist, as I was walking to the hospital. So, there's, when they say there's like nowhere for jail's like the #1 mental health provider in the US.
It is. This is a problem.
Because there's nowhere else for these people to
Thank
go.
you, Ronald Reagan.
Yeah, and
There's
the fact
another
is,
good Republican
those
program.
people are being further traumatized in jail. I mean, they're usually the victims of crime, not the perpetrators, contrary to this police officer's opinion. They're more often to be victims of crime. It was a very upsetting conversation.
It was.
Anyway,
Clearly.
and certainly if they get in a prison situation and you have mental health problems and you can't get the treatment that you need, because they're going to treat your behavior as criminal. I mean, this is so demoralizing and destructive to our communities. And it makes me feel unsafe that we have police officers running around with this attitude that a person who might be having a mental break could possibly be killed because the police officer is incapable of assessing the situation correctly.
So that's health justice.
Exactly.
Yeah,
No,
absolutely.
I have a couple comments on that, and then I have a broader comment that I can leave y'all with. The prison state is the basin in which people that are unwanted or unvaluable are poured into, right? If you don't like, my girlfriend's a healthcare lawyer, she thinks about this a lot. I was talking last night to a doctor up in, wherever I was, Ann Arbor, who works in Chicago in prisons. We have built a bunch of rules that make it illegal to be a combination of poor and sick. A great example is if you have HIV in a lot of the Gulf states, any crime you are charged with is amplified by virtue of you having HIV, and like in theory, maybe you could have given somebody HIV, even like getting into a bar fight, something like that. Other kinds of health problems that end up being enforced carcerally, also in Louisiana, which is where Kelly worked. If a cop picks you up and you are a woman or a trans person and you are carrying condoms, that's enough evidence to indict you for being a sex worker, so you're put into prison. Wherever a person is not profitable, they are put into jail. Jail is the basin where folks spill over. On the other side, and I hate looking at making moral arguments through economic lenses, but things are so fucked up, this ends up being the case. We finally have quantitative evidence, I think we all knew it already, that in the counties where Medicaid was expanded, not only did mortality drop by fucking 6%, which is huge, 11% of people of color, the recidivism rates, how often people that are in the system go back into it, dropped, plummeted, right? Because people have fucking healthcare access. I did a study in Louisville, I think, looking at what were the most frequent causes of frequent utilization, both in the hospital sector and in the prison sector. And often, at least in this part of Kentucky, people go to jail for being homeless, right? You get picked up for sleeping in a park, you go to jail, you get out of jail, nowhere to go, so you sleep in the park, you go back to jail, you're just back stuck in the thing. The same thing happens in healthcare too. The two kinds of frequent utilizers in healthcare are folks that are going to jail for similar reasons. They don't have a place to live, and so they're dealing with addictions. They just keep picked up through the cycle, or folks that don't have access to primary care, who are sick, who have emphysema or whatever, and just don't have a doctor nearby they go to, so they go to the ER. One of the reasons that I'm really interested in fighting for the broader health justice movement, one of the reasons that I'm interested in single payer, this is my closing statement, I was going to segue, is that it is a relatively benign transformation, right? All it is a change to the financing model. Instead of us paying premiums to a private company, we just change that into a tax and pay a little bit less of it. That's literally all it is. This is not a big, dramatic, burn down the Capitol and make a new one, but a cooler one kind of movement. But it is a tool, right? And what it does is it forces us to square up against a lot of the broader problems and a lot of the greater exploitations that happen under capitalism. And one of the things I like it is you can compare and contrast a thing like gerrymandering and healthcare, both insanely important and have vital and essential components in any kind of broader movement. But a lot of people don't vote for a lot of reasons because a lot of things they get to vote on don't fucking affect them, right? People have been actively disenfranchised, to which voting on abstract policy has no material benefit or no material change to their life. Healthcare isn't that. Everybody, I was talking to a canvasser up in Albany, an instructor at whatever the school is up there, RPI? I think it's RPI. They started a healthcare campus. They wanted to go canvas trailer parks in the Troy area. And so this person, who was a person of color, was canvassing a trailer park and talked to a dude who had big fucking SS tattoos. It was like, hey man, do you feel fucked over by healthcare? And the guy went off. Absolutely, he's being jerked around by his insurer. He can't get the care he needs. This canvasser radicalized a fucking neo-Nazi. This is the raw potential of this kind of thing, right? And I would encourage you to, I know in Pittsburgh, there's a lot of other locals, particularly in this part of the country, also where I'm from, that are beginning to adopt health justice as a big part. I'm not saying you should is, but I'm encouraging you to, of how they organize. Pittsburgh is forming a health justice working group that attempts to understand how people in Pittsburgh are being fucked over by capitalist healthcare, and then using that as a leverage to both one, expand membership because it works, and two, like do broader popular movements, right? Everyone knows they're being screwed over. Nobody likes how they're being treated by healthcare. Everyone knows that they're the weakest link, and that they need to live in fear of their own bodies so someone else can turn a profit. And that's explosive. You find someone and you ask them, what is happening? How do you feel screwed over? And you build the solidarity you need to explain, or to, like, with them, imagine a better world and articulate your vision of stuff's required to get there. And kind of what you were saying before, one of the reasons that healthcare, I think, is so sticky. Like, there's this idea of, it's okay, cool, Tim, you want to build a fucking food clinic. Well, that takes 8 years to work. Like, that can get gutted in an election cycle. No, it doesn't, because things are so bad. Any material benefit will be fought to the death by its constituents. Think, for example, of the ADAPT protesters. The DSA Disability Working Group is insanely cool. I'm going to go talk to them in Buffalo in about a month. Like, ADAPT protesters really understand, which is mostly a leaderless movement, understands that everybody is like, well, I am putting my life on a 2002 Honda CR-V that I don't take very good care of. It's like one rusted thing bending the wrong way, and I can be disabled for the rest of my life. Like, and ADAPT understands that when they fight for disability rights, they're fighting for literally everybody, whether or not they understand that solidarity themselves. And so they literally put their bodies on the line to defend Medicaid because they understood who they were fighting for. I think if you give more people access to incremental, like the steps towards the path of health justice, toward the path of single payer, they also will too put their bodies on the line. We can't ask unions to do it because unions are fighting different battles and have been marginalized or have been whittled down for the past 30 years, right? Doctors and nurses are trying to do it, but they're only one part of the larger battle. I think the only way we attempt to achieve this is through mass popular movements, and the only way to do that is fucking talking to people and breaking through all these stupid artificial divisions that we've been told we have to have. And so I hope y'all will consider this as part of your chapter. Once again, like, people across the country are putting together resources. We are happy to give them to you. We will fucking, if you don't know how to canvas, and nobody knows how to canvas, we will like go on, like we will talk to you over the internet, or someone will come here and talk to you, like I'm doing right now. We will walk you through how you build this stuff. We'll walk you through how to build a data structure. We will take the things that you want to fight for, whether it's a local bill, a state bill, or something else, and find out how to build it. We'll show you the conversations we've had that have worked. We'll talk about ones that haven't. If you like find other chapters that live nearby, Pittsburgh, I'm really into. They were really feeling the fire. Is experimenting with this pretty heavily. It's like no one rides alone. This is a national movement with regional implications. So I would encourage you to please consider it. And if this is a thing you decide to do or don't, any broader questions, I am a tool. Sorry. My only goal is to be a resource. This is the only thing I care about other than my girlfriend. And she's also a healthcare activist, so we just mostly care about this. I am here for every DSA chapter I talk to. If you have questions or things that you need, or if you want to be connected to the broader movement, know who to talk to, and are relatively like scattered groups, talk to me. I am here or there, realistically, whoever there is, to help. This is a thing I care about, and I think everybody else will too. That's all. Thank you so much.